So I'd like to welcome our panelists up next, and we're going to have several panelists that are going to talk with you a little bit about their work. And then we have microphones, as you can see, in each of the aisles, so afterwards you'll all have a chance to ask questions. We cut out a break because we have a lot of content that we wanted to fit in for you this afternoon, but we figure you'll kind of get up as needed to use the restroom or get some water or whatever you need. Our panelists are on their way up, so I'm going to start telling you a little bit about who they are. In the interest of time, please stay because we have exciting panelists. Don't go anywhere. We're going to lock the doors. So, like I said, I'm going to go ahead and get started introducing our panelists. First, we have Dr. Lonnie Jones, an associate professor at the University at Albany in our School of Social Welfare. Dr. Jones's research and scholarship interests are concentrated in the area of evidence-based practice with a focus on the use of culturally relevant approaches to enhance one's psychosocial competence. Specifically, her research is focused on the use of feminist group work approaches with women of color. Dr. Anju Lee is an assistant professor in the School of Social Welfare. Are we short some chairs? Will our graduate students in the back please help out? We're apparently short three chairs. Sean Trefoso, Beth Karchik, and Marissa Reamer, if you can help out with getting 3 chairs, that would be great. Sorry about that. Dr. Anju Lee is an assistant professor in the School of Social Welfare who specializes in prevention and intervention research in child welfare. She is currently working on the Kinship Care Demonstration Project funded by the Children's Bureau. Dr. Julia Hastings is an assistant professor in the Schools of Public Health and Social Welfare who conducts research on health and mental health disparities among ethnic minority populations, African American mental health, welfare participation dynamics, and ethnic minority women's health issues. Her research projects focus on the interrelationships between race, mental health outcomes, health conditions, risk and protective factors, and poverty. Her research grant portfolio includes funding for the National Institute of Minority Health and Health Disparities, NIMH, the Ford Foundation, and the Robert Wood Johnson Foundation. Dr. Allison Appleton is an assistant professor in the Department of Epidemiology and Biostatistics at the School of Public Health. Her research follows a developmental origins of disease framework where exposures occurring early in life have significant consequences for health over the life course. She focuses specifically on early life experiences of psychosocial adversity and the physiologic and molecular mechanisms through which such exposures may affect chronic disease risk later in life. Dr. Lynn Warner is an associate professor and associate dean for research at the School of Social Welfare. She received an MPP, Masters of Public Policy, from the Kennedy School of Government at Harvard University, and MSW and PhD degrees from the University of Michigan. Dr. Warner's research is focused on understanding patterns of drug use, both prescribed and otherwise, to identify strategies to improve services, especially for at-risk groups of youth and immigrants. Dana Peterson is associate professor in the School of Criminal Justice, University at Albany. She conducts research primarily in the areas of youth gangs, violence, prevention, and treatment, and is particularly interested in how these are structured by sex and gender. And since 2002, she has been a co-director of SOAR, Service Outcomes Action Research, an ongoing research practice partnership between LaSalle School, St. Anne Institute, and the university. Nicole McFarland, voted 2010 New York State Social Worker of the Year, is the Executive Director of Senior Hope Counseling, Inc., and a doctoral candidate at the School of Social Welfare, honored with the William J. Reed Endowed Scholarship for her dissertation. Her research, practice, teaching, publications, and consulting has focused on geriatric addictions. Nicole represents Senior Hope Counseling as an active participant in the Hearts Initiative, which is focused on ACE-informed programs. Dr. Steve Markell is the Senior Director of Behavioral Health at the Center for Disability Services and member of the Hearts Initiative. Steve became interested in the problem of adverse childhood experiences as a result of his work with people with developmental disabilities and their vulnerability to ACEs. A provider in the field with over 34 years of experience since earning his school psychology degree, Steve will be presenting at the National Association for Dual Diagnosis Conference in Miami in May on the topic of ACEs among those with disabilities. Betty Devine is currently a field liaison for the School of Social Welfare and serves on the board of Senior Hope Counseling. She was an Albany County Protective Services caseworker before becoming a policy analyst for Family and Children's Services in the New York State government for 20 years, and subsequently was an evaluator of school-based and child welfare services in San Francisco. She received MSW and BA degrees from UAlbany. Joanne Trinkle, Director of the Sidney Albert Training and Research Institute at Parsons Child and Family Center, has worked with at-risk children and their families and led numerous statewide initiatives. Joanne was co-director of the HEROES Project funded by SAMHSA. She helped lead development of the National Child Traumatic Stress Network Resource Parent Curriculum and co-authored publications and co-led training by the NCTSN Complex Trauma and Resource Parent Work Groups. Wilma Alvarado Little is Director for Community Engagement and Outreach at UAlbany Center for the Elimination of Minority Health Disparities. A healthcare interpreter and trainer with over 25 years' experience in the healthcare field, Wilma advocates for linguistically and culturally appropriate health services. She has been instrumental in the development and implementation of hospital and clinic-based programs and serves on numerous state and national boards which address multicultural issues. So it's an honor to welcome all of our panelists. Thank you so much for your time today. They're each going to speak for about 7 minutes. A couple of them have some PowerPoint slides, and others are just going to talk with you a little bit about their work. And then you'll have an opportunity to ask them questions afterwards. So whoever wants to start can start.
I'll start because my PowerPoint is up, so. How do you open this? This is go forward? Okay. Oh, okay. Hi, I'm Anjuli. I'm a faculty here, and I specialize in child welfare research. As a child welfare researcher, I became interested in adverse childhood experience. Mostly, it's an negative effect on health and social outcomes. And I just, since I'm going to, because there are really more esteemed colleagues out there, I'm going to speak very fast in about just 5 minutes, so you have time for the questions. And I want to just talk to you a little bit about the work I'm doing with Dr. Larkin. This is a data based on actually representative sample of a New York State resident, 18 and older. Again, you've seen this so many times, so it's just same pattern. But what is really interesting about this data is that it's not clinical sample. It is really based on adult, age 18 and over, and then represent all race and income group and educational group. So you can see that white is that I don't have my pointers, but 40% have no ACE. But surprisingly, the red, I know panelists cannot see that 13% of them have 4 and more ACEs. So we are working on this paper, and let me see whether I can operate this. Yes. What is really more intriguing is that, again, this is nothing new. You haven't seen it, but it's because it's representative sample, we really know that this is not something for the, just limited population. Is really actually that representing New York State resident. That you have a sort of what you consider in research jargon is a relationship, really strong association between the cumulative ACE scores. You can see 40%, the 4 or more at the end of that, line, that almost like 40% or more than 45% of the people who actually use substance or mental health services. And that's the New York State data. And then compared to people who doesn't have ACE, they are service use, behavioral health service use is like only like 1/4. So you can really see this is another thing, you know, that I'm addressing. The already people already know about these issues, and so. Having said that, I just want to get your attention to what is really needed in the next step. What we're going to publish, that's really important for us. We are publishing, but what really important is that I want to think about what the next step has to be. Next step is that, as you, many of you know, that ACE is done mostly people who are already 18 and over. As you remember those scores, there is a limited research on ACE and outcome among children and youth under 18. So we really began to understand that, and this is one of the reasons that I, as Dr. Lucky introduced, you know, my project, we're going to collect ACE score, related scores, and the experience data in our kinship care project. And then second area that I really want to think that is, despite a lot of recent advance in research, we still really need to identify what are the effective interventions for the kids before they turn 30, before they turn 18. You know, this is, of course, what you consider million-dollar questions. We still have to work on it, especially for the children in childcare system. There are really more promising approaches these days. Still, we really have a lot of work to do identifying and testing interventions. And lastly, for that reason, it is very important. I'm so glad to see that we're having this dialogue, and thanks for the opportunity, you know, given to us. It is really important that we're not just saying this, but my experience working with a child welfare practitioner, I really began to understand that how important to getting their wisdom, they are getting input when we're designing intervention and listening to, you know, then influencing policy. So that's what I think the triangle, research, practice, policy really matters. Thank you. How to turn it off? Yeah, okay. Perfect.
Does this work? Okay. Hi, everyone. I'm Allison Appleton, and unlike probably most people in this room, I'm an epidemiologist. I don't have any clinical training, and I don't work with clients. So what I'm here today to tell you is the public health perspective on how we think about issues of childhood adversity from a public health perspective, and particularly in influencing chronic disease risk over the life course. Oh, sure. Is that better? Okay. So what I'm going to speak with you today is about psychosocial risks from early in life and also psychosocial assets and the relationship between these factors and cardiovascular disease later in life. So I work from a developmental origins of disease framework, and this basically means that exposures or experiences that occur early in life have long-lasting impacts on health and functioning. This can occur through the accumulation of risk factors over time. So one adversity can set in a cascade of risks that cumulatively build to impact health, and also through critical periods of development. The previous speaker spoke about trauma exposure during brain development and how that can disrupt myelinization and neuron development. So in either case, these adversities, there's often a lag of many years, if not decades, from the time of the initial exposure or adverse experience to the health outcome. So increasingly, epidemiologists are appreciating this perspective and are studying how early life exposures to adversity can influence health outcomes. And cardiovascular disease in adulthood is the condition people are focusing on most specifically, and the evidence base is largest to date on that. So I'll talk about that today. And what we're finding is that childhood psychosocial risk factors, childhood psychosocial adversity harms cardiovascular health. And there's also a corollary in the literature that childhood psychosocial assets can promote or buffer cardiovascular outcomes later in the life course. So I'm going to present for you briefly two sets of results that I've done in these areas. I'm a data person. We like numbers, but I'll keep it brief.
So we used data from the National Collaborative Perinatal Project, which was a birth cohort initiated in the late 1950s, early 1960s, where moms and babies enrolled in this cohort and were followed intensively during the childhood period. Their home environments were assessed, their cognitive ability, their emotional functioning, their health status, and then we picked them up in adulthood and assessed their cardiovascular outcomes and a range of other parameters as well. And so what we found are that kids who grew up in households characterized by low socioeconomic status and also kids who had poor emotional functioning, these are the correlates with adverse events. We didn't actually have data on trauma exposure in this cohort, but these corollaries, when these kids had sort of both hits, they were significantly more likely to have high levels of this inflammatory marker that indicates being at high risk of cardiovascular disease. It's called C-reactive protein. It basically is associated with cardiovascular morbidity by way of atherosclerotic plaque formation in the arteries. So kids who had this double hit of poor emotional functioning and also growing up in low SES environments had this elevated level of C-reactive protein 40 years later. And this level of CRP that's elevated was at or above what the CDC and American Heart Association indicate as being at high risk of cardiovascular disease. So these are not trivial increases in risk. We're talking about clinically significant risk for cardiovascular disease that happens later in the life course, attributable in part to these adversities experienced in childhood. Now, the flip side of that is this asset question. So could psychosocial resources or assets from early life promote your cardiovascular health later in life? So in this same sample, we looked at cognitive ability, attention regulation, and positive home environment factors of these kids between birth and age 7 to see would they grow up to then have a favorable constellation of of cardiovascular health factors. So we're not talking about the absence of adversity. We're talking about tangible resources from early life that really may matter for health later on. The American Heart Association defines favorable cardiovascular risk as what these factors are in the circle here. So having favorable levels of blood pressure and BMI and cholesterol, not smoking, and so forth. So if you have this favorable cardiovascular profile in middle age, you have a tremendously low remaining lifetime likelihood of ever developing cardiovascular disease and also increased longevity. So what we found was that these childhood assets, measured at around age 7, attention regulation, cognitive ability, and having a positive home environment, these kids were way more likely to have this favorable cardiovascular health profile in middle age. So a 1.5 to 2-fold elevated increase of having this favorable cardiovascular profile. What we also found is that any one of these factors is health promoting, but having all 3 of them was even better. So having high levels of attention, high levels of cognitive ability, and having a positive home environment increased the likelihood of having this favorable cardiovascular health profile over 4-fold odds. So 1 is good, more is even better. So what this underscores is that childhood is a sensitive period of development, and that midlife cardiovascular health is attributable in part to these early life psychosocial risk and protective factors. So the prevention of childhood adversity is an important and huge public health priority in its own right. This work also suggests that if we are effective in our promotion and protection of these children, we may also be benefiting cardiovascular health for a lifetime. So I didn't get a chance to bring articles that detail the studies that I just talked about, but please do email me if you'd like a PDF of anything I've spoken about. So I'm going to sit down, but thank you.
Hello, everyone. My name is Wilma Alvarado Little. Am I hitting the mic okay? All right. And I don't have a PowerPoint. But what I was asked to do is talk about some of the work from the perspective of the Community Engagement and Outreach Corps from the Center for the Elimination of Minority Health Disparities. When we originally wrote the grant, which is through the National Institutes of Health, we had looked at 2 communities in what is defined as the smaller cities in New York State, because when people think of New York State, they think of the 5 boroughs or whatever is portrayed on Law and Order, as opposed to the rest of upstate New York. Well, you do hear Albany and some other upstates if somebody's fleeing New York City on television and they're coming up here, right? And then we get them. Okay. So two of the populations that we had targeted when we wrote this grant was the African American community in Albany and then the Latino community in Amsterdam. Through our research, we have found that these are not mutually exclusive. So what we started to do is we were listening to what the community had wanted us to provide some guidance and some support through the center. So with the Albany community, we started to look at issues involving Black male empowerment and issues involving our youth through the K through 12 system, but focusing primarily on the middle school through high school and up. We started to do a series of presentations through the communities involving the spiritual community, some of our other academic organizations. And what we were asked to do is talk to them about what does health disparities mean for a middle schooler and for a high schooler. Because what happens is supposedly, magically, when somebody turns 18 or 21, they're supposed to have all these wonderful health practices that they may not have been empowered to figure out on their own before then. So our task was to plant the seed. So what we did was we brought in the definition of what we called the IOM-10, right? Asthma, heart disease, cancer. And what we did was when we took it into our schools was, and our other community groups, was to also include areas of incarceration, violence, substance abuse. And then after we would go ahead and present these, the information regarding health disparities and some healthy choices that could lead to healthy outcomes that could be made as they would be age appropriate and within that individual's control, we would ask for a very, very simple evaluation for the students to give us their feedback on, because we asked them to please provide us with their thoughts because we needed to hear from them. Okay. And so some of the things that we heard back from their evaluations, keeping in mind that these are middle schoolers and also high school students, they said, I like that I wasn't interrupted. Somebody asked me what I thought and they listened. Somebody else said, I really like that you talked to us about incarceration because nobody talks to us about that. And another student said, I learned that if you're of a different race, you die a different way. So this is all very powerful information that we have included and continue to go ahead and move forward with when we're asked to do a presentation. Most recently, we were asked to do one for the Latino Si Se Puede, a conference that was held in October. And here we are with our tools and having our points and including all the information that we had received from our students in the past. And then I look at the audience, I see that, are some of the students understanding what I'm saying? So I raised my hand and I said, you know, is this easier in Spanish or in English, or it doesn't matter? Because here I am, this adult, speaking to them, and some of them weren't understanding. So some of the students had a language barrier, so I was able to go ahead and present the same information in a language that they understood, which I thought was kind of helpful to them, but boy, was that a teaching experience for me. The other work that we've been doing is with our adolescent community in Amsterdam, primarily with the Latina community. It's called Young Moms on a Mission. And this was in response to the community telling us that they're very concerned that their ages for adolescent pregnancy were becoming younger and younger. So we were able to develop workshops in an environment that we hoped would be non-judgmental and that would promote trust. We asked them what they wanted to hear about, and a lot of these young moms wanted to hear about, you know, how to have a healthy relationship, what the relationships they were in, was that okay? Because there was no comparison as to what is healthy. You know, and so how can you know what is quote unquote healthy if you don't know anything different but a physically or mentally or any type of abusive relationship? So that was one of the examples that we did. We were able to provide the information in a way that was culturally and linguistically appropriate to them, to the point that now we have built the trust to the point that they will participate in surveys, and now that we have IRB approval, to dig a little bit deeper and collect a little bit more information, the data which will be turned over to the community so that they can tell us what they would like to do with it and present next steps. So thank you for allowing me to present this information, and I think the next person's coming up. Thank you.
Good afternoon. I'm excited to spend a little time sharing information with you about disparities in diabetes and depression outcomes among African Americans and Caribbean Blacks. Part of why I think I'm here is that I actually enjoy riding the fence between social welfare and public health, since I have a joint appointment, as Dr. Larkin mentioned earlier. I found as a practicing social worker when I first started, I was actually started off with teen moms in labor and delivery, and then you find holes in problems or in programs that you couldn't resolve. And then I went off and pursued a PhD and realized I led a much happier life working with teens. So my path toward diabetes and depression actually began when I was a doctoral student, when I tried to pursue research that truly focused on racial and ethnic minorities. I grew up in California, so the conception of services from my perspective was always a little different from what was presented to me. And so I always had questions about, well, where is the culture? That when we work with African American populations, where is it that we focus on culture? We were very clear on the research projects that I worked with what Latino culture was. We were very clear on understanding what Asian American culture was. We were clear about what immigrant cultures brought. But it was very interesting to me that when we specifically started talking about what was culturally related from a policy perspective, an interpretation of what is it that African Americans need? Things were short in terms of trying to understand how does that interplay within service provision. So my research and my questions were luckily answered by the National Institute of Minority Health and Health Disparities. I was a recipient of a K-22 to study just that. So my research focuses on identifying illnesses and what illness means in terms of diabetes and depression among African Americans and Caribbean Blacks. And then I hope to gain the information from my project to transform social service provision by meeting the needs of racial and ethnic people so that they make sense. So where I started this is that historically African Americans and Caribbean Blacks truly have a distrust of the social services that are provided. In that they distrust society, they've distrust health professionals, social workers, public health workers, and part of it is inconsistent implementation of service provision. So what my project was funded to do was not only to first interview with qualitative study, qualitative implementation of a study, to ask exactly what is cultural about health outcomes, but also to try to place in a grander scale using a national data set. So I'm collecting data nationally, trying to reinterpret, well, what does it mean? So we can get closer as to what was most helpful. So the study is that I'm in the field currently right now. It's understanding diabetes and depression among African Americans in California and New York. So the purpose is to gain an in-depth understanding about illness perceptions, about self-management, about provision of services from physicians, from social workers, from public health professionals, and to learn about how they utilize services and what services are not available. For me, it was very nice to have these face-to-face interviews audio taped. I expected about 45 minutes, but people talked to me for about 3 hours. So I learned a lot about what was right and what was incorrect and what can be improved upon. What I learned from studies, just preliminary data, at least from the California set, I won't blame New York yet because I'm in the field still, is that oral health actually is an overlooked condition that accompanies many African Americans who suffer from both diabetes and depression. If you think about the kind of interventions that are created to improve diabetes outcomes and improve depression outcomes, we always say eat a healthier diet. And then we go on to say eat more fruits and vegetables, etc. Well, part of the problem with this population is they can't follow the advice, and then they get labeled as being non-compliant. So the only accessible and affordable oral health care treatment that this population had access to, the hospital dentistry clinic only offered tooth extraction. receive dentures. They couldn't receive a root canal. They couldn't receive. Those were all services that would have improved their oral health and helped them to comply with some of the recommendations. So I've interviewed people with as few as 8 natural teeth, and I've interviewed folks who have all of their natural teeth despite many of their other combining health conditions, and they were all very willing to show me their mouths. So they opened up and we counted, and it was kind of an interesting exercise. People will share with you everything. I've seen dentures come out and be put back in. So if we are concerned about the public's health, and dietary change remains a feature of how to manage diabetes, we do need to come to some response to how do we accommodate oral health outcomes. So in asking what kinds of foods these respondents ate when he or she had fewer than 16 teeth, that's just only the top part of your teeth in your mouth, the answers varied to overcooked vegetables, which, if you know from a dietary perspective, really loses all the nutrients, to only soft fishes, to some were only drinking liquid diets. And so none of them mentioned that they were eating crunchy food. So no carrots, no celery, nothing crunchy. And if I had more time, I would share other details. But what I am learning from this population that feeds into a national survey is that sometimes we try to look at one condition and we overlook another complex condition. I have found often with the people that I'm interviewing that depression often accompanies diabetes because, especially folks who are low income, because they don't see a way out, they don't see a way of being healthier. So I'm hoping responses to my survey will help me lead to improve on what kinds of outcomes that we can train health professionals to ask for. And I believe that's my integration for ACEs. Thank you.
Hello, my name is Nicole McFarland, and I'm honored to be here with all of you today to talk about Senior Hope and ACEs. Just to give you an overview, Senior Hope is the only outpatient clinic, freestanding OASIS-licensed nonprofit agency in New York State catering exclusively to 50 and older who struggle with addictions. And a few years ago, the founder of Senior Hope, Dr. William Rockwood, and I sat down and reflected upon the idea of taking a look at becoming part of the Hearts Initiative and exploring how ACEs could be beneficial to Senior Hope. At first, there was a little bit of reluctance because we realized, the focus was more on children and early childhood trauma. But after some reflection, we realized that so many of our older addicted adults at Senior Hope struggled with co-occurring issues and physical ailments. And we began to realize the value that rolling out the ACE questionnaire would have at a clinic such as Senior Hope. Over the last couple years, as we have integrated the ACE questionnaire and worked collaboratively with Dr. Heather Larkin at the University at Albany, we have done some preliminary exploration of what these scores look like. And across gender, what we have been seeing is that a vast majority of our client population have 4 or more scores of yes on the ACEs. It became evident that so many of these elders, due to the generation that they grew up in, struggled with devastation, trauma prior to age 18, and they didn't have the mechanisms, the services in place to really address these issues, such as CPS and law guardians, So what we realized is they needed a forum in which to begin to discuss some of these issues that they were dealing with that had been repressed for so many years and that had a direct connection between their addiction, their mental illness, and their physical complications. So we launched not too long ago a trauma recovery group with a seasoned clinician with child welfare CPS expertise by the name of Jerry Nathan. And in that group, we've begun to see individuals in their 50s, 60s, 70s for the first time sharing how the experiences they had prior to age 18 really set the stage for a lifetime of suffering, and how important it is to offer older addicted adults with co-occurring issues a forum in which they can feel safe and valued and feel comfortable sharing among their cohorts these devastating experiences. We've heard from Mary Seiss about the healing process, and that's exactly what these older addicted adults need, because at Senior Hope, it's about quality of life and what kind of legacy that they want to leave behind. Many of them do not want to be remembered as mom or dad who died in a drunken stupor. They want to be remembered as mom or dad, grandma or grandpa who had a vital role with their children and great-grandchildren's lives. So we have been extremely grateful to work collaboratively with SUNY Albany and to engage in lecturing on the local and national level, as well as publishing. Dr. Heather Larkin and I published in the International Journal of Aging and Human Development, focused on some of what we're doing at Senior Hope and how it's so important, even though these individuals are at a later stage in life, to acknowledge how their trauma early on has so influenced and so impacted their lives throughout the life course. And we always say that it affects 3 generations. It affects the elder, it affects their children, and it affects their children's children, their grandchildren. So if we can begin to provide an environment where they can get the education and support that they need and begin to talk with their primary clinician about some of these early childhood traumas, then we're offering an important service. And it just lends itself to the value of prevention and how if we are able to devote more time, attention, and resources to early childhood trauma, that perhaps we will not see as many elders suffering, with lifelong addictions, mental illness, and chemical addiction. So we really look forward to ongoing collaboration, not only with SUNY Albany, but also with the Hearts Initiative, which has played a major role in the work that we do at Senior Hope. By being able to collaborate with fellow colleagues who are very vested in incorporating the ACE questionnaire into their programming, it has allowed us to share our enthusiasm and excitement over the work that we're doing. So I thank all of you for your involvement. Take care.
Good afternoon. I'm Betty Devine, and as a member of the board of Senior Hope, I first want to acknowledge Nicole's leadership in implementing the ACEs questionnaire and trauma-informed programming at Senior Hope, but also promoting the awareness of the impact of ACEs on the senior population throughout the community here in the Capital District, as well as nationally, and her publications with Dr. Heather Larkin. I'd like to state that the Board of Senior Hope is extremely supportive of the programming that is being done to address the trauma that many of our clients has experienced. And I'd also like to state that at many of our board meetings, one of the topics of conversation that we're all concerned about is having placing a high priority on our agency culture and ensuring that it supports the dignity of our clients, because we know they have experienced, many of them, severe early childhood trauma as well as trauma throughout their lives. For me, as a former Child Protective Services caseworker, being on the board of Senior Hope has helped me integrate many of my professional experiences. And as I reflected upon them, I believe Senior Hope tells the story about the impact of not preventing ACEs or intervening early to reduce their impact. I see three primary areas of impact. First is the personal pain and suffering which many of our clients have experienced, the suffering in silence over the years, and their use of substances to numb both the emotional and physical pain from this early trauma. Second, because of what has happened to them, many of our clients play a role in the intergenerational transmission of ACEs as a parent or grandparent. As we heard this morning, the ACE study identifies having a parent or household member as who is a substance abuser as an ACE category. Third is the costs incurred when intervention does not occur early. We see the substance abusers, the seniors at Senior Hope, and they have many health care needs as a result of the physical ravages of long-term substance abuse. And with the aging baby boomer population, the costs of these health care needs can be astronomical. However, despite this somewhat dismal picture, as our agency name implies, I see hope. As Nicole discussed, age-appropriate trauma-informed intervention is helping our clients to heal and to reduce or abstain from substances. I think we are teaching them cognitive, emotional, and social competencies, that we do offer something concrete, as well as do most service providers seeing clients with trauma. I believe Senior Hope has immediate potential for health care savings, particularly in long-term health care. I also see hope and that the State Office of Alcohol and Substance Abuse Services took the initiative to promote the efforts of Senior Hope and increase the awareness of ACEs to substance abuse treatment providers throughout the state by hosting a webinar, which both Heather and Nicole presented the implications of ACEs related to substance abuse. I see hope with this symposium and all of you who have attended, and I was particularly inspired by the keynote address by Susan Dreyfus. Having spent most of my professional career in public policy, I can say ditto, ditto, ditto to just about every point she made. There are many barriers that impede our ability to promote the strengths of our clients. However, I see hope right here in the capital region community through the HEARTS initiative, the coalition of capital district agencies, which has coalesced with partnership from the School of Social Welfare under Heather's visionary drive. It's focused on creating an ACE responsive service system. And currently, HEARTS is evolving and continuing to grow in membership. I think immediately it offers the opportunity for member agencies to begin learning more about what each other does, what service modalities and interventions are being used to address trauma. Through that, we know no one system or agency can meet the needs of the clients it serves, all the needs, and particularly family members. And with this, we can, through this coalition and learning more about each other, we can help focus on coordinating services among us to all of our clients and families. However, most importantly, I see hope for the future. I believe HEARTS offers an opportunity to serve as a laboratory for building an interdisciplinary cross-systems local infrastructure, one that is capable of more holistically and efficiently responding to the needs of individuals and their families through a trauma-informed approach, as well as specifically identifying the policy barriers in terms of at the federal and state level on laws, regulations, and funding. And I all too well know there are a multitude of them. I am quite impressed by the strong commitment of leadership at all levels, certainly by Bill Wolf here as the executive director of LaSalle, who is a member of HEARTS, through the School of Social Welfare, our dean, Catherine Breyer-Lawson, the commitment of the program directors in the agencies and direct staff to make a change right now in the capital region. And I'm also I have hope that sitting here at the panel today, I see members from different schools within the university. As we know, the university is the resource for the research and evaluation that's going to be necessary for us to demonstrate that what we do really makes a difference and is deserving of investment. And last but not least, I'd like to thank all of you who came today and took time out of your busy schedules to learn more about ACEs. And I'd like to leave you with this final thought or question, and that is, how much longer do we delay in making a societal commitment to invest in the prevention of the costly outcomes of ACEs? Thank you very much.
Hi, I'm Steve Marcal, and I work at the Center for Disability Services. I'm a psychologist there, and so I have some comments to make today. I don't have original research to present, but I have some comments based on my involvement over the last number of years and my interest in the issue of ACEs, in particular with developmental disabilities, with people who have developmental disabilities. And I'll explain why that's interesting to me, especially in something that I feel so important for us to address in my field as well as in all the others. Susan Dreyfus this morning mentioned the idea that our clients are our neighbors, and that resonated with me because who are people with developmental disabilities? They are our neighbors, and they're our families, and they're our children, and they're living in our communities. Now, when I grew up on Long Island, that wasn't the case. in the 1960s and 70s, you did not see especially more significantly disabled people when you went out in the community because they were placed in institutions. And many of you probably know, and really no talk, even a 7-minute talk, about ACEs and developmental disabilities would be complete without mention and remembering the abuses that people with disabilities, developmental disabilities, suffered in New York State. And you probably know about Willowbrook and how Geraldo Rivera, in another earlier career, broke the story by breaking into the back wards of Willowbrook and putting the cameras on the abuses that were going on there. So now these folks truly are our neighbors, but we haven't historically treated our neighbors very well. And people with developmental disabilities have taken it tough. One of the things that I wanted to mention that occurred to me while I was listening to the other speakers, for some reason this thought crossed my mind, there's been a recent shift away from the use of the term mental retardation, and we're now saying intellectual disabilities, so I just wanted to take a moment to mention that. And the reason that's important is because when I speak to people who have developmental or intellectual disabilities, very frequently they have a history of somebody calling them the R word. And that is a traumatizing experience in and of itself. And so, unfortunately, words take on meanings, but right now that's the meaning that that term has. So if you can all shift to intellectual disabilities, I know a lot of folks would really appreciate that. So in our clinic, we see lots of folks who have experienced trauma, and a few of those may have experienced that trauma in institutional settings, but it was my observation that we had a lot of other folks who we were seeing. But of course, it's a clinic sample, so maybe I'm seeing more people than is really the case who have these sorts of trauma histories. So I was interested, you know, sort of in the back of my mind in this, and I started coming to the presentation. So I want to also thank Dr. Heather Larkin and others at SUNY who've made this investment in our community through their personal commitment to this topic. And so I started learning more about it, and I looked into some of the literature on it. So I'm just going to share just a little tiny bit of that with you this morning, because I thought, my intuition was that it would be the case that things were worse in terms of trauma. The risks were higher for people with developmental disabilities. So there was I'm just going to mention a couple of these studies. I have about two and a half hours worth of material or something like that on this stuff, but I'm going to give you the extreme highlights of that, or lowlights. There was a study done by Sullivan and Knutson. This was back in 2000. They looked at 40,000 school records, and they compared students who had disabilities with those who did not have disabilities. And what they found was that the risk of neglect was, I'm going to round up here, 3.76, I'll say 4 times higher in students with disabilities. The risk of physical abuse was about 4 times higher, and the risk of sexual abuse was about 3 times higher in those students. And the other findings were that children with disabilities were maltreated at earlier ages. They were more likely to be maltreated as preschoolers. In fact, the majority of the abuse and neglect that occurred happened to preschoolers as opposed to school-age children. Even though you can do the math, it shouldn't be that way. So one of the things that I discovered in looking through all the literature on this is a rule that holds up is vulnerability. And any group that's more vulnerable, even if it didn't seem to be intuitively the case, if you're more vulnerable, you're more likely to suffer abuse as a group. And that seems to hold up to me until someone shows me something otherwise. And of course, the effects these folks found on child's education was quite disruptive, and they didn't do as well in school as others with a similar ability. Another thing that occurred to me today is I wondered how many people with intellectual disabilities we're making, because we look at the research on the impact on the brain of trauma, and how do you determine whether someone has an intellectual disability and their eligibility for services? It's based on their IQ score and their daily living abilities. Well, if those are going to be affected by brain function, so you wonder, we have somebody with a 75 IQ or 78 IQ, what is it after lots of trauma? I don't know. I don't know if there's been any research on that. One doctoral dissertation that I thought was very interesting, and I'll wrap up in a minute, but this one showed, they looked at trauma, and it was Rebecca Wald. She looked at, not trauma, but asked parents, it was very clever, an analog study, she called it, and she looked at, are parents more likely to endorse or admit that they used corporal punishment with their kids based on the level of disability? And in fact, the lower functioning kids, and this was the opposite of what I thought before I realized about the vulnerability piece, that the lower functioning the children were on an adaptive behavior measure, the more likely the parents were to say that they used physical punishment with their kids. So that was kind of surprising to me. Just one mention on a couple other things. Sexual abuse. Women who had, or adolescent girls actually, who had physical disabilities in another study were shown to be about twice the risk of other girls the same age. So one other thing, Child Protective Service workers should be aware of. I know there are probably some folks here coming out of that system, and there was actually a study that looked at that. Manders and Stoneman in 2009 looked at this, if anybody is interested in that study. And what they found is that children with disabilities were more likely to be seen as having characteristics that contributed to their abuse. Many CPS workers felt more empathy with parents, and the services recommended tended to be more focused on the child and less focused on intervening with parents when the children had disabilities. And although the differential treatment was more pronounced for less severe injuries, even with injuries that were severe, such as concussions or broken bones, workers responded differentially based on disability status. So I guess all of us in all of our fields, in my field, we certainly made plenty of mistakes. CPS workers, I think, need to be more aware of how their biases may be impacting them. And for me, I just wanted to mention this book that is by Nancy Raza and Dan Tomasulo. It's Healing Trauma. If anybody's working with people with intellectual disabilities, the power of group treatment for people with intellectual disabilities. And they really go into not only treating the people who have disabilities who've experienced trauma, but also offender treatment using a group format, and also preventive strategies, protective strategies that you can work with folks on. So it's an important area, and my piece of this is hopefully to keep developmental disabilities in the conversation. Thanks everybody for coming. It really is a great thing.
Good afternoon. I'm Joanne Trinkle. I'm the director of the Sidney Albert Training and Research Institute at Parsons Child and Family Center, where we serve both Parsons Child and Family Center and the staff at Northeast Parent and Child Society, now through an affiliation that is known as Northern Rivers. We've been a grantee for the National Child Traumatic Stress Network for 2 rounds of doing a research kind of study using the Real Life Heroes model, which Heather, thank you so much. Dr. Kagan is doing a training here in a couple weeks to tell you more about the Real Life Heroes model. My role in that project was sort of implementation. We had our model developer. He's all about fidelity to the model. And we've had a lot of conversations of how do we get clinicians in a real agency with real challenges around 80% no-show rate and different challenges around sticking to what is known as evidence-based practice. How do we get people to do it? That was really kind of, they looked at me and said, all right, Trinkle, make them do it. Okay, so how do we, kind of figure that out? And we've learned that there are a lot of layers to, and we've heard it all throughout today, that whenever you're talking about ACEs, whenever you're talking about trauma and the impact of trauma, we're dealing with 2 really large child welfare agencies within the capital region. Trauma is really difficult even for clinicians to talk about. They don't want to go there. It's really interesting. Sometimes they find that opening with a child and family, and they find themselves kind of shying away and changing the subject. And we've noticed that when trying to get people to delve into this clinical treatment, we had to first start to talk to them about ACEs? What about you? What about the triggers? What about the different things that are sort of impacting your ability to stay there, to stick with it, to be that container to kind of take it all in? But then what do you do with that? So then the other kind of impact when we found out of our study was we had all these staff who were quitting, getting sick. You know, you start to bring it up and you start to hear about other people's trauma, that those secondary traumatic stress reactions started to become evident and real for us. So what we've been learning is to be able to do this sort of work, we have to have, we have to be mindful about the several different layers to it. And we've had a couple of different counties come to us and say, help us develop a trauma-informed model of care. And when you start to talk about that, part of it is just getting everybody on the same language. And that's where ACEs has been very helpful for us, because it's just sort of a really common, it's accessible for information to have a baseline for people to understand, oh, if you've had these experiences, it has an impact on you. Sometimes I think in child welfare, we think of these severe instances of abuse, neglect, what's in the media, those kinds of things. But when we started to talk to people who are doing this work, it's just there's a series of instances in the kids' and families' lives, but also we're working with children, and we find that working with children, it's not really the children who become the focus of our work, it's their parents and their caregivers. So the layers that we kind of had to build around was more than just the treatment model. How do we train caregivers? How do we train caseworkers so that everybody's speaking the same language? Everybody is focusing on the what happened to you rather than the what's wrong with you. So in the 2 cycles of our study, the most interesting pieces of this were, which we started to just say out loud to people, hey, listen, if you start to do this work, people get worse. You will see worse behaviors, and our data tells us that after the first 3 months, the behaviors that kids were demonstrating spiked. And that was what was terrifying to the staff and the clinicians doing the work. But then we showed them the data 6 months later, and then you see this recovery that was much lower than when they started. So by giving the clinicians data to show them, hey, I know it was rough there for a while, but look where we are now. The recovery is much better than when we started. That's where we started to understand the power of actually showing people in the field data that makes sense to them, data that's about their caseload. They started to see, oh yeah, I get that. When they were scoring the actual assessment tools to gather the data, which was really hard to get them to do, it was more like threatening your paycheck kind of stuff. You have to do these measures. But when they started to do the measures and we started to have this nice kind of stack of information to give to them, they started to realize, hey, wait a minute, this does work. It is worth it in the end. But then the second layer of that was the more we had them doing it, the more we saw the impact on them. So then we had to build in sort of protection around what's a safe environment for people to be able to do this work. How do you talk about secondary traumatic stress without everybody going on a disability? It's frightening. It really is a reality when you start to talk about the impact of this work. How do you build in those protections and those layers? So that was the work that we've been doing, we continue to do. If you come to hear Dr. Kagan, he'll tell you more about the actual treatment model, and it's based around the idea that attachments are what create healing. So how do we help build in those attachments? But that's basically the work that I've been doing, and thank you very much for having me.
Good afternoon, everyone. I'm Lynn Warner. I am a faculty member here at the School of Social Welfare, and I'm also the Associate Dean for Research. And my first request to you all is, since I'm very disappointed I wasn't able to come to the whole day, I really wanted to get some input from you all about what are the research questions that would be most relevant to you in your practices that you think maybe we should start paying a little bit more attention to here at the school, and thinking about ways that we might be able to think about generating some projects, some dissertations, and so forth. So I'm going to actually offer Heather's email, because I know you all have her email, and then she'll get those to me. The second is I really just wanted to share some of my own research interest and actually concerns about trends in intervention for children, many of whom are in the child welfare system, who've had traumatic experiences. And when I saw that the topic for today was the rapidly expanding science of brain development and the impact of trauma on the developing brain, I thought that my own research interests around the use of illicit substances and also the use of prescription medications really creates a lot of opportunity to question some of our approaches and some of the influences that are sort of our go-to interventions in terms of first line of defense is often things like medication rather than other approaches. So I was really quite taken with the overlap of thinking about the effect of trauma on the brain and then the effect of psychotropic medications on the developing brain and the effect of illicit drug use on the brain, and thought maybe it would just be helpful to step back a little and give some information about what we know about medications that are being prescribed for youth. So before I go into this presentation, can I just ask if there's anyone who works for the pharmaceutical industry? I'm very even-handed, but I think some of my messages might be perceived as contrary. So were there hands? Okay. I don't think I'm okay anyway. So just starting with the experiences of trauma that children experience, we might know about those experiences, we might not, but certainly we know that the behaviors that then follow from those experiences are in fact the things that are going to grab the attention of teachers and doctors and family members. Like, acting out, aggression, depression, in a way that those behaviors then bring the attention of people who are likely to suggest prescribing medication as one potential way to address the situation. And what we know from lots of data is that the groups of kids who are getting psychotropic medications, it really does vary. The rates are quite variable in terms of looking at kids who have particular types of diagnoses or kids who are in foster care compared to others. We know that in the general population of youth, that approximately 4% of kids might receive a psychotropic medication in a given year. And these are things like antidepressants, antipsychotics, stimulants. My own research looking at some Medicaid data to compare rates of medication use across different groups of kids, for example, low income, children with developmental disabilities and children in foster care, you do see this sort of interesting relationship with what Steve was talking about in terms of vulnerability. The more vulnerable the group, the higher the rate of medication. So, and it could be the more vulnerable the group, the more they've experienced trauma or adverse events, and so that might explain it. What we see is youth in poverty, about 11% are prescribed a psychotropic medication. So overall, it was 4. Youth in poverty is 11. Children who have developmental disabilities, about a quarter are prescribed medication. And then children in foster care, I think we know this. This is often in the media, that the rates of psychotropic medication for kids in foster care are quite high. They're also quite variable depending on the state and the local context. So the rates of medication range from as low as 13% to as much as 77%. So the other thing that we know is, and this is where I'm really raising concerns that I think we need to be a little bit vigilant about. So it's not that we don't necessarily think that the medications work, but it is a little bit of concern that most of the drug trials have been conducted on adults whose brains are already developed. There have been some trials that have been done on youth, and those tend to have been the stimulants. But those studies don't look at the impact on the brain. They look at things like did the symptoms resolve, and did maybe some adverse side effects occur. So the trends in medication use are increasing, and they're increasing in two different ways. One is different populations of youth are being medicated, and the kids who are already being medicated are getting more medication. And so this trend toward polypharmacy is really quite remarkable. And this is where the science and the practice diverge. There's no science, except for a couple combinations, that suggest that the multiple antipsychotics, the multiple combinations of antipsychotics and stimulants that kids are getting, there's no rational pharmaceutical prescribing reason to do that. So then we have to question why is this happening? And some people suggest that it's just a trend towards symptom-based prescribing. So if you have this symptom, we have this drug that we think can address it, so we'll add it. There's a greater cultural acceptance of pharmacology in general. There's a reluctance to discontinue medications that are already in place. There are pressures from parents, teachers, and sometimes clinicians to add medications to existing regimens in times of crisis or when new symptoms present themselves. And there are limits in the access to psychotherapeutic treatments. And there is aggressive marketing by the pharmaceutical industry. So, for example, there are some stipulations in the ACA, because we know that the pharmaceutical industry has developed a lot of relationships with doctors who prescribe and encourage them to offer these prescriptions. There's a prohibition against doctors receiving some of that medication or some of that research money in the ACA, but it leaves open the possibility of doing that for things like physician assistants and nurse practitioners, who in some states can prescribe as well. So I think there's no question that there will be continuing trends toward the use of medication, but it's not completely out of our control to change the impetus for this to be the first line of defense. And I'm not saying that everybody does this, but because the rates are so high and the rates are increasing, I was heartened to hear the fidelity of the model requires people to wait to see the data. If the symptoms spike, maybe wait a few months and then you'll see that they decline rather than address the symptom with a medication first. So certainly there are countervailing pressures. And I guess I also want to say that the reason that I think it's worth questioning is because of what we started with at the beginning, which is we don't really know what the impact of psychotropic drugs is on the developing brain. We know that other drugs, like drugs that kids experiment with during middle school, change the brain. We've done brain imaging studies to show that. But there's this reluctance, I think, to really investigate what are the consequences of doing this. There's an assumption that it will help, and then we think it will help, so we don't need to put in place some of the research and investigations that we might need to really confirm for ourselves the situations under which maybe you do want to take the risk. It will change your brain, but the alternative is worse. And maybe it won't change your brain in a way that's ultimately going to be problematic. So, as I said, I would welcome hearing your thoughts about any research-related questions that you think the school can help with, whether or not they're around my own research interests in psychotropic drugs. Thanks.
I'll try to be quick so we can have one time to hear from our last speaker. Good afternoon. My name is Dana Peterson. I'm from the School of Criminal Justice, and as Heather has already indicated, I am a co-director, or one of several co-directors for the Service Outcomes Action Research Project, which is a partnership between the University, LaSalle School, and St. Anne Institute. These two institutes are both assessing ACEs among the populations they serve, and I want to talk just a little bit about the larger framework that is SOAR, the Service Outcomes Action Research Project, within which they're using knowledge about ACEs to improve treatment services. So the university partners are faculty and students from the School of Criminal Justice, the School of Social Welfare, including Julia Hastings, also from the School of Public Health, including Heather Larkin. And at one time, we did have the School of Education involved. So you can see it's a multidisciplinary partnership. And the goal of this partnership is to develop and implement evidence-based practice to improve services by systematically gathering and analyzing and using data on clients, treatment services, and outcomes. And it's a participative partnership with agency management and all levels of staff involvement in decisions and actions of development, implementation, and use of the SOAR approach to evidence-based practice. We started with a pilot study from 2001 to 2005. In which university researchers, by that I mean a lot of doctoral research assistants, spent time gathering information to help us do a number of things. One, to develop, along with staff, a vision of their program theory of change, or their logic model. What do they expect to happen as a result of their services to clients? We used this pilot study to develop and validate measures of client characteristics, staff provision of services, in-treatment and post-treatment outcomes that they expect from those services, and then also to provide preliminary findings about the expected relationships in the logic model. So again, in this pilot study, the university researchers gathered information. We gathered it from face-to-face interviews with young people at both of the agencies. We did face-to-face interviews with their primary caregivers. We did surveys with each client's treatment team, and we also collected information from their case records, from each of the individual clients' case records. And based on measures developed and lessons learned in that pilot study, we entered the current stage of the program implementation, which is called DIP, the Data Informed Practice Process, because we like our acronyms. And through this DIP process, we are working collaboratively with St. Anne and LaSalle to increase organizational capacity to implement evidence-based practice. And by that I mean practice based on their own evidence, not necessarily an off-the-shelf program that they are implementing. And we're doing this by implementing a permanent data collection system for the residential programs. And in this phase of the study, it's the data are actually being collected by staff on a day-to-day basis as part of their service provision. So we are doing this at multiple points in time. We're gathering data at intake, including the ACE questionnaires. We are gathering information, or the staff rather, are gathering information from the youth themselves, from surveys of the primary caregiver, as well as from standardized instruments, including the BASC, the Behavior Assessment System for Children, and then finally from the client's case record that is produced as a result of day-to-day practice. And through doing this, as I mentioned, we're creating an in-house data gathering system for staff to collect information about all clients in their care and to use these data to make program level as well as individual level case decisions to continually improve services to youth and families. So there's just two key aspects that I wanted to point out about this. One is that through this SOAR framework, the agencies are assessing not just who clients are when they come in the door and when they leave service, the pre-test, post-test model that is commonly used, but rather they're also assessing what is happening to and with clients while they are in their care, so that we can help determine what aspects of service are working better or worse than others, and whether some youths and families respond better to some aspects of treatment. So trying to avoid the one-size-fits-all approach that Susan Dreyfus talked about this morning. In order to know what to keep doing or what to change, we have to connect the services provided to the outcomes that are achieved. And the second thing is that it's an iterative and adaptive process. Again, Susan Dreyfus this morning indicated that evidence-based practice is a process and not a destination. So we learn, we change, we reassess. We learn, we change, we reassess. Populations also changed. The populations of these two agencies have grown to be different over time than when we started this partnership back in 2000. And in fact, the ACEs information and assessment was not even a part of that original data collection effort. So we're implementing that now. Practices also change, and so our long-term partnership is intended to provide continual feedback for learning about services. And in the brief, 30 seconds I have left, I just wanted to mention two challenges that we're facing. And again, these were prefaced this morning in Susan Dreyfus's talks. One is contracts and budgeting. We don't have any funding for this evaluative aspect built into the agency's budgets. Stakeholders want to see evidence of effectiveness, but agencies are not provided with funding to evaluate the effectiveness of their work. And so our partnership, in our partnership, we argue that learning about services is part of providing effective treatment. So what if, for example, gathering and using evidence about services provided were built into the daily rate charged to counties? How far could we get beyond the regulative to move into the integrative and the generative if we were to be able to do that? Secondly is cross-collaboration, cross-agency collaboration, and this is connected to funding. In our pilot study, as I mentioned, we used intensive resources on the part of the university to connect with families post-treatment to determine the extent to which the gains that were made during treatment were maintained post-treatment. The agencies don't have the resources to do that kind of intensive follow-up, but other agencies could partner with them to provide some information about how youths and families are faring post-treatment. And by that I mean information from educational outcomes, information about arrests, information about recommitment. So there's an opportunity here where we could all work together to kind of think about how can we improve services within each of the agencies by sharing information across agencies. So we commend LaSalle and St. Anne for their commitment to learning about their practice and how to best address youth and families with high ACE scores. And we also commend their innovation in partnering with the university. We've heard a lot about university partnerships, and that is one way to do this kind of work and to think creatively about how we can think about how to best serve, how do all of us can engage in human servicing practices. Thank you. You have.
So the joy of being at the end is that I can shorten mine to say to protect time. But I was calculating. I think we were slated at 7 minutes. So after we're finished, I'll point out those who went over their 7 minutes. No. So I wanted to start with this piece, and it's called May Day. Should we celebrate the fall of the Berlin Wall or mourn the failures of democracy? This morning, I imbibed the most supreme eternal joy, spiritual sung by Marian Anderson. To think she may be more remembered for singing to 75,000 people, and some of the sarcophagus of the great emancipator in Jim Crow D.C. South. After being refused Constitutional Hall by Daughters of the American Revolution, instead of for that stunning voice. Deep, clear, muddy, bell-like, almost flat, sometimes with the crystal longing of deep river, and the loneliness of separate dining. I wanted to start with that piece because I thought of the many things I could speak of. And the last minute, as I began to think of my work and its connection to ACEs, I began to think of a curricular curriculum that I've designed specifically entitled Claiming Your Connections, a curriculum designed to work with women of color specifically in group settings, whether in substance abuse or mental health or shelter settings. I wanted to pull from that the utility of the power of creativity, specifically around the use of poetry in therapy. And what becomes important is that we as therapists, as clinicians, begin to create an ambiance, a space of healing, a ground for clients or consumers for active exploration of herself. And very specifically, I like to ground my work in cognitive-based treatment, but also in Black feminist therapies with women of color. Because Black women's historical struggles and with the emphasis on the personal is political, emotional wholeness, empowerment, and social change become very key to the core of therapy for these women in the healing of traumas in their lives. And specifically, just thinking of poetry therapy as the intentional use of literature to generate healing and personal growth. And what I've been very successful in is using literary works, specifically using poetry, looking at that piece written by Cheryl Clark called Mayday as a piece where these women can reflect and respond and begin to rewrite and retell their stories of trauma, their wounds, their stories of mental illness, and their stories of drug abuse. Their stories of torment, their stories of abuse. So quickly we ask ourselves, how does this work? Myself as a healer, you want to be able to choose a very appropriate piece for the work that you do, and since I tend to run groups with women of color, I draw on a lot of the works by bell hooks, which becomes very helpful in terms of consciousness raising and the rethinking of these women and their lives in terms of traumas within families, traumas from a very historical perspective. And where we support the consumer to juxtapose her life with poems or other literary pieces through comparison and contrast. And finally, by being able to help her apply a written poem based on their lived experiences. And this creative experience and process is therapeutic within itself. It allows us to express and examine the content and the dimensions of their traumas and their internal lives. So finally, just to say that when individuals, when Black women who have been faced with many traumas in their lives put their emotional upheavals into words, their physical and mental health seems to improve greatly. So thank you.
I want to thank our panelists so much, and thanks to all of you. Now, while some of you may need to leave at 4, we want to stay a little longer so that you have the opportunity to ask questions. So we'll take a few questions from now till 4:15, and we want to reassure you that we are very interested in continuing this work. We've been doing ACE events for a while. This was a bigger symposium. We're so thankful to LaSalle for supporting us in this. The next ACE event is on March 26th. The flyers are up front. But as you can see, there's also microphones in each of the aisles there, and people with questions for our panelists, I hope that you'll come up and ask your questions. And you can also follow up with me, hlarkin@albany.edu, to ask a follow-up question or request articles too. But again, we'll stay a little bit longer here because we want you to have a chance to ask questions of our panelists, and are so thrilled that you came to join us for the day. So who wants to be brave and come up to one of those microphones in the aisles there? I know there's got to be some questions that came up from our exciting panelists. Great, we have somebody with a question.
My name is Suzanne, and I work in...
Is that mic turned on? You might need to talk a little closer to it.
Hello?
Great,
Yes.
that's great.
Just a thought, really. Thank you so much, first of all. This was an incredibly informational day. Will probably take me a month just to go through all the information that I received. My thought is, I too have concerns from my family standpoint as a foster mom and an adoptive parent, as well as a teacher, and currently working as a kinship care provider for the county. Hi, Jerry. The concern about that you were speaking about, I forget your name, so pardon me, about the diagnoses of children and the huge numbers of children that currently are on medications. And you know, when I speak with my families about the difficulties that are arising and they think that medication is the solution to the problem, I certainly do not direct them or tell them what to do. However, I do impart to them, I hope, the importance of having knowledge before they move forward to become the doctor and diagnose their child with some, you know, ADHD, ADD, or depression, because some things mask themselves for something else. So you know, just the importance of diagnoses. And in my county, we're a little limited with places to go for that kind of work. Most people, there's like one center. A lot of private doctors don't always see new patients. So, you know, what do you do as the care provider for the family? What information can I give them that, besides just my words, which probably aren't that much, but, you know, how do you direct people with these children to look for alternative means to help their family?
I have to answer that question. That's a very challenging question. You raised several things that are challenges. One is the availability of providers who actually are trained in things like trauma-informed care, and or who are trained in pharmacology and trained in diagnosing. So there is a lot of work to be done in terms of all of the providers and some of the work that people have described here in terms of the information that needs to be shared across providers about what seems to be working in what setting would be very helpful in terms of creating that picture of, you know, we like to think that medication will help and it will help quickly, but we need, if we could take a step back and get information about where are the kids and where are they doing well, what are the things that are happening there that we could try to have the care providers, case managers, parents really involved in that kind of discussion would be one thing. The other, I think, would be to try to develop maybe more collaboration or outreach and identification of people who have made it through without medication. And this is a different angle, but sometimes the students might, the children, the families might need some support in saying no, you know, saying no to the medication. And so that might be another possibility. And I suspect other people have thoughts about this as well, but it's a challenge. It takes a certain bravery, I think, to say no to the medications.
It's really being countercultural at this point to not have the medications or to question the medications, I would say.
Okay, thank you.
New York State Kinship Navigator. Today we talked about trauma all day long. We talked about abuse and neglect. and everyone here has commented on today, but the one form of trauma that I didn't hear mentioned, and I just raised it up to see if any of the panelists want to comment, or Heather, is loss. I just didn't hear it today, and I was surprised to see it missing in the descriptions of trauma. By loss, particularly in my population, all children in kinship care have lost their parents, i.e. also all children in child welfare have lost their parents. The usual model or example you're looking at is they've lost them in child welfare because the parents have abused or neglected them. But there is the loss of the parent to the child. Is that a form of trauma?
It's one of the ACE categories, actually. If you, prior to the age of 18, have you lost a parent in some way? So it's a very general question, and it could be divorce or death or, yeah.
And in the work that you're doing here today, though, we really never commented on it. We always said abuse or neglect. And I just want to, so maybe I'm missing it, but the emphasis on loss is really important to our population.
Absolutely, and that is, when we talk about ACEs, maybe we should emphasize more what all the ACE categories are, but that's one of the categories that can accumulate, and then those accumulation of ACEs are associated with all of these high costs later life health and social problems that we've talked about today. So yeah, absolutely, loss is a part of that. And then in terms of ACE response, how do we include our interventions around helping people with loss? One member of the Hearts Initiative is community hospice, actually, and they've talked about that quite a bit, that they're helping people, many youth, primarily because of the issue of the ACE category of having lost a parent in some way, and often there's other issues going on as well. Some of the panelists may have additional thoughts.
Yeah, I think I'd summarize it again. I've noticed this at another discussion I was in where we talked about ACE on one side, and then you talked about trauma and abuse and neglect on the other side, and they seem to be kind of conflated at times. And while the ACE study has these 10 questions, they don't really always seem to me to be, creating the full spectrum as being acknowledged all the time. We go from one side to the other, and the two are often just not looked at as a full spectrum of loss and trauma-related situations. I don't know.
It's an important question and also a distinction, because while the ACE adverse experiences, the ACE categories are associated with these later life health and social problems, there's an assumption that they're often traumatic, but there's actually a difference between an adverse experience and whether or not something is traumatic, and then there's trauma, and then there's post-traumatic stress disorder too. So that might be actually one of our good follow-up events that you could help us with too, is kind of helping people to walking through some of the distinctions between adversity, trauma, post-traumatic stress disorder, and how do we bring together our response strategies and think about all of this holistically.
Is there a word that covers it all?
Well, I would suggest that ACE response, but there's probably, because that is inclusive of loss, and we're talking about recognizing ACEs and thinking about how do we respond comprehensively. But there's also opportunities to build on the ACE research too, and one of the things that Anju Lee has been looking at is adding neighborhood risk and understanding the impact of social violence too, and the World Health Organization has called for that as well, to add to our understanding of ACE categories the category and like an 11th ACE of social violence that could include neighborhood risk, living in a war zone, and that kind of thing. And there are other future research questions that develop from here too, in expanding our knowledge of ACEs. But then what I'm very interested in with ACE response is how do we integrate the knowledge that we currently have and work together, practitioners and researchers, and also bring new research questions from practice that we support practitioners and providers in better understanding the impact of their work in those areas too, when there's a lack of research. So it's not just bringing research to practice, but also listening to practitioners as well. And so how do we move forward in researching some of our ACE response strategies, which would be increasingly holistic, hopefully. So I look forward to some more future events, and other people might have thoughts, and other people might have questions generated from your excellent ideas as well.
Hi. Just in terms of trying to mitigate, ACEs early on, as soon as they occur, Are you currently working with any domestic violence agencies where there would be a focus and an effort to get funding to ensure that there is intensive counseling for kids in families where there has been domestic violence?
Yes, we've had some domestic violence agencies pretty regularly attending some of our ACE events from early on, and then some recent inquiries into joining the Hearts Initiative too. So there is some connection there, and what you're recognizing too is domestic violence being a category of ACE. So that's one of those adverse experiences that is included currently in that consideration of accumulation and then later life implications. So really important when we're thinking about integrating for ACE response, including domestic violence agencies too. I'm curious what our panelists might want to respond to about that. Another question?
Let's see. Yeah, in some ways, yes. It's been published, but if you would be interested, I'm also willing to train clinicians on its use. But you can find most of its detailed content in several of publications that I've written. Sure. It's Lani, L-A-N-I, middle initial V, Jones, and I can give you my email address, ljones@albany.edu. But if you Google my name or if you contact me, I would be willing to send you any information.
Thank you very much.
On
the issue of medication, I know some nutritionists had mentioned the idea of the fish oil, the EDAs and whatever, and also magnesium and everything. And I think some of, how much is that being looked into nutrition-wise? And also we know that the stress increases the cortisol, so does, all the donuts, all the food, the GMOs affect the baby, affect everybody. So I think we really got to start looking at the food. The glycemic index, has changed so much because of the gluten in the wheat. So there's all these other issues, and then on the other side, all you have is TV commercials saying, oh, take this, but you might die, get cancer, tuberculosis, whatever. And I myself was supposed to take Humira and Mexidectrine for, arthritis and everything, because my factors were really high. And I said no, and I've done other things, body, mind, and spirit, and I'm 66 years old. They told me I couldn't walk 5 years ago, and now I am still working full-time. And I think this is not addressed because it's not politically correct. Also, that the drug companies, they're pushing everything. I mean, think of the effect. I'd like to see a study done on the effect of, when you're at the airport, if somebody gives you a package, that's really mind control, what I mean? It makes you crazy. Think of how many advertisements little kids are seeing. Oh, take this antacid. My grandson said he needs antacids. I think, what I mean? And the other thing they say, oh, take this, you ate this. You never question, did you eat 5 candy bars, 6 pieces of pizza, and a stick of pepperoni? That is never mentioned. And I think we really have to look at this. And we can't, I'm into more natural medicines and herbs. Actually, pharmaceuticals just take a piece of that, not the synergistic effect. And, I really think we need to do this because we are just blindsided by, oh no, you got to take this medicine, what have you. But there's all healing things. I just did a presentation. I'm not a nutritionist. And my thing was, God is food's pharmacy. And I'm not denying medicine is important. I think we have to look at holistic medicine. I was supposed to have 2 operations, never did it. They said with all the stress attacks I had as a child, my adrenals were shot. What we have to do is reestablish the adrenal level, and then your body maxes out. So I really would like to see more research into reality. And this isn't a criticism, I'm just saying this is not
some more research on interventions that are not necessarily medication interventions and more holistic kind of interventions.
And the effects of how food and all the poisons and everything else. You know, the PVCs and there was just a whole thing on PBS today about the BPAs and how the other chemicals are almost just as bad and nothing's regulated. So
I think it reinforces what other people have said is there is a very, just like we're a litigious society.
I can't hear you.
Just like we're a it's on? Oh, sorry. Just like we're a litigious society, we are a self-medicating society, and we're a medication-seeking society, and we're really so our diet, drugs, anything that we put in our bodies, we think we know what we're doing, and marketers are reinforcing message. But I think in addition, I think we do need a much better understanding of the interactions between these things. I mean, we just don't, like hard scientists really need to study this as opposed to soft sciences up here.
Could I just add one thing? They say, I did also Chinese medicine, that acupressure, the AMA says they can't prove it. Well, they've been doing it for 5,000 years. You know what I mean? I mean, this is...
Mm-hmm. Thank you.
Really important points. I would like to invite Bill Wolf up just to kind of close us up and send us out.
I actually wanted to just validate and confirm what she said, because at 18 I was misdiagnosed back in '79 with a seizure disorder, and I was put on medication in 1979 for a seizure disorder that I never had. And that was a long time ago, because I'm 52 now. And I went to a nutritionist the following year, thankfully, because a college friend who was older than I saw that I was being mistreated, basically. My PTSD had never been assessed, which was really...
I think there's really great agreement with what you're talking about.
Yeah.
It's a black hole, and we don't know, and we need to do a lot.
And the nutrition helped me so much that now I just became a health coach last year through the Institute for Integrated Nutrition, and I think she's spot on with what she's saying. And I think that if we don't speak out about it, the fact that our kids medicate with sugar, and that adults, I mean, we're the baby boomer generation, a lot of us in this room, and we were raised with tons of sugar. It's like the first mood-altering substance that we had access to. And if we don't come to grips with that and how it's impacting this current generation with obesity, we're just...
All right.
Thanks, Chris. I didn't see you at first because the light was shining on you. Sorry about that.
Good to see you, Heather.
Look, I want to bring stuff to a close because it's been a long day and a heroic day. To the folks still in the room, my goodness, you get grades for durability and great interest, but I don't think the vacant seats have anything to do with the content or the shift. It's just simply the time that went by. I want to just make a comment to you guys. I've gone back and forth a couple times already with Susan. She's on a train to New York City to do other things, and she said, "Bill, did I do okay?" And the amount of time that she's been quoted, the frequency with which, you know, and I think you get the sense of why we were so pleased. I was so pleased when she agreed to come. And I would offer to you guys that in some of the business that we've been in over the years, the last people we wanted around were folks from universities. When I've been at LaSalle School for about 30 years, and we weren't all that interested in things. We frankly weren't. The College of St. Rose was across the street. We had nothing to do with them, but we would assume they might as well have been, you know, on Pluto. We did not want our kids interfered with. And you know what I'm talking about. So much has changed, and to have a panel of 11, 12 folks like yourself giving these brief connections, giving this whole sense of the connection between health factors and the work we're doing, and that we're all really in the business of public health, is fascinating. And folks have said, dangerously sometimes, I think, that all good ideas, all good change, all good revolution has been born on the campuses of universities and so on. And to the degree that you're going to ally with us, if you will, I'm speaking as us as a provider, and there's lots of us's out here, we really need to get together. Last night at the dinner we had, one of the guys was talking about, for crying out loud, we've got enough talent and enough smarts and enough creativity, but we stay by ourselves too much. And he was looking out of the room, about 60 people, saying, what the hell are we doing, and not coming together as a voice for children and families, not just one group of children and the other group of, not in these selective ways, but in a more broad way for the benefit of things. So as Susan told us last night and challenged us, so when someone comes to your community, they don't evaluate you based on how many new roads you've built and how many new buildings you've got or how many sports centers you've got. They ask you the direct question and look in your eyes and say, how are the children? And when you can honestly answer that the children are well, the other stuff will take care of itself. So I thank you all for this energy, this generation we've had, and it's been such a pleasure for myself, my colleagues, and I don't mean the folks at LaSalle, but colleagues generally in this field to get together and do this. So thank you very much, and thank you, Heather.
Thank you so much.